right, kids, here we go. Chapter 32, Part 2, Soft Tissue Trauma. Finishing this chapter up. So let's talk about managing wound healing and infection. So we're going to mostly talk about throughout this is really just taking care of some specific injuries. So as we talk about managing wound healing and infection, you see basic measures should be used in the pre-hospital setting. So when we're talking about dressing and bandaging and those things. Wounds that appear infected, not healing properly, should be properly dressed and bandaged to promote healing and prevent further infection. And of course, there's pain control. As we look down our slide, those control measures may be indicated to manage some discomfort associated with that wound. So we're going to just kind of start at the top and head to the bottom. Talking about the body, looking at how to bandage and do some things with some soft tissue trauma. So scalp injuries, so these things tend to bleed profusely. So direct pressure is usually effective in stopping that bleeding. Significant trauma may indicate potential skull damage. So we're thinking such as fractures. Excuse me. So you need to balance the need for bleeding control with the risk of causing further damage to the skull. So if skull damage is evident, then you just apply pressure to the areas around the break rather than directly on the fracture. Now facial dressing, so if possible, reassure your patient to help reduce some anxiety and stress. Most people will have a little bit of stress over some facial dressings, but apply some direct pressure to control the bleeding, which tends to be heavy in the facial areas. Once again, we're still talking about a heavily perfused area of the body. Now, if an avulsed tissue is present, attempt to place it as close to its previous position as possible. And then, of course, with the face, we hopefully should be thinking about airway assessment. So assess for any signs of airway compromise, as facial injuries can potentially obstruct breathing. So if you have someone that has to be on their back, they're on a board or whatever, and they have a lot of facial bleeding, that's something to think about with airway management, because some of that blood can easily get into their mouth and cause you an airway obstruction. So pay attention to that. Ear or mastoid dressing, so do not place a dressing in the ear canal. So instead, apply it along the length of the external ear. Use some gauze sponges if you have those to help stop the blood loss effectively. Avoid direct pressure in the ear canal. And then, as I kind of mentioned, do not attempt to directly stop blood from the ear canal. Here's the thing, there may be some cerebrospinal fluid leakage, and halting that blood flow could increase the skull pressure. So just place a bulky dressing over the external ear for protection. Of course, rapid transport if you think there's cerebrospinal fluid. Now we're talking about the neck. So minor injuries, they obviously can escalate into some major complications. So minor neck laceration can lead to an air embolism. Small puncture may penetrate the spinal canal. Anterior open wound can disrupt the airway. So use an occlusive dressing to prevent air from entering the circulatory system, and then make sure that we're monitoring and ensure the dressings do not interfere with the blood flow or the movement of air through the trachea also. And then shoulder dressing, so apply direct pressure to control bleeding, use a sling and a swath. Most of this stuff is really EMT review kind of things, but we're just going to hit it anyways, just for fun. So truncal dressings, so assess for underlying trauma and torso injuries. Cover open wounds with an occlusive dressing, taping only 3 sides to allow air release. Assess breath sounds in cases of open chest wounds. Check for that pneumothorax or hemothorax. So continually reassess the patient for changes. Groin and hip dressing. So use a dressing and bandage application combined with direct pressure to control blood loss effectively. Now, when feasible, managing genitalia injuries, if you have a provider of the same gender, that's gonna make things obviously a little more comfortable in these sensitive areas for people. And then remain professional, protect the patient's privacy throughout the whole care process, obviously. Hand, wrist, and finger. So place the hand in a functional position whenever possible to aid in the recovery. And then if necessary, splint the hand and wrist to limit motion during healing. And then whenever feasible, leave fingers exposed to allow for monitoring of circulation. Moving elbow and knee dressing. So movement may cause dressings to shift from their original position. So if larger wounds are present, joint immobilization is advisable. Remember, you had those skin tension lines, and high tissue stress can complement the management of even smaller wounds between those tension lines and just some high tissue stress. So it's crucial to assess distal neurovascular status regularly, because we're talking about elbow and knees, so things distally. So think, more southbound, I guess, downstream. Elbow injuries carry a higher risk of neurovascular compromise. Ankle and feet, apply direct pressure to control bleeding. And then if it's arterial and not controlled by direct pressure, you may need to move on to a tourniquet proximal to the injury. So, obviously it's going to go above the injury. You want to use, when we're talking about that tourniquet, so you want to use whatever your local protocol is. Obviously, you go back to that. However, there's two lines of thinking there. You have kind of a high and tight idea, which is, say there was a laceration in the forearm area. High and tight would be up high on the arm, and that way there's a number of reasons why. One is that's kind of accepted, one as a general layperson. However, that's not us, hopefully. But number two also is with the, remember earlier when we talked about with that laceration, there can be some, with that vasoconstriction, you can get some of the vessels that kind of climb back up inside a little bit, and they can shrink up trying to shut things down. So you may end up putting a tourniquet on and increase some blood pooling that might happen. Then the other side is 2 to 3 inches above the wound, which is typically more accepted within the EMS industry probably. However, where you're at might do something different, so just pay attention. So abrasions, superficial wounds, it just results from the loss of part of the epidermis. That's due to rubbing or scraping against a rough surface. So assessment and management, we're talking about typically just a small amount of blood, so it could, obviously could be painful, prone to infection. However, don't clean it necessarily in the field. Rubbing, brushing, or washing can lead to additional bleeding and necessary pain. So just cover the wound lightly with a sterile dressing. And then a laceration, we mentioned that's a cut inflicted by a sharp instrument or by blunt force that produces a jagged wound. So you have lacerations and then incisions. So that incision is more of a clean linear cut, and then that laceration is kind of a jagged or irregular cut. Obviously, there's potential for deeper injury, so lacerations can injure structures that are beneath the skin. Continuing on with lacerations, so seriousness factors. So the seriousness of a laceration depends on a couple things. As you see, depth, so the depth of the wound, and then also the structures that are damaged beneath the skin. Now, lacerations can be a source of significant bleeding, so remember that first priority in managing a laceration is to control the bleeding. Then puncture wounds. So a puncture wound is an injury resulting from a piercing object. Obviously, that can cause injury to those underlying tissues and organs. So the depth can't always be determined in the field. Seemingly superficial puncture wounds may involve vital organs. So just always suspect that possibility of internal injury and shock. So still talking about assessment and management. So assess the potential depth of that wound based on the direction of the travel, the type, the speed, obviously some proximity to important internal organs. Now typically there's not significant external bleeding, but there may be some extensive internal bleeding. So some unseen damage to other structures and systems as well. So treatment for this is similar to that for open wounds. So you look for an entrance and potentially an exit wound, take steps to prevent infection. And then if the patient refuses care, inform them about the risk of, potential infection if the wound is not managed. Then there's an air injection risk also. So in certain puncture wounds, like from a gun at a close range or an air pressure device, air may be injected under the skin. So we want to monitor for edema and then treat swelling with ice. Still continuing on with puncture wounds, so impaled foreign objects. Special type of puncture wound, if the object's still embedded, just immobilize that object to prevent further injury, and then transport the patient to medical care without removing the object. Remember earlier we mentioned in the event it dealt with airway or messed up compressions, then we leave those guys in there then. So assessment and management, still talking about basic management points for impaled objects. So, don't try to remove the impaled object, just use some direct compression, so avoid applying pressure on the impaled object or immediate adjacent tissues. Don't shorten the object unless it's too cumbersome, so motion may damage that surrounding tissue, and then just stabilize the object. So use bulky dressings to stabilize the object, immobilize the extremity if an extremity is involved. That looks pretty painful in that picture, doesn't it? So limit the motion as soon as possible to minimize damage to surrounding tissues. We want to secure the object, so secure that object the best possible way you can. Obviously provide a reassurance to the patient, help alleviate some anxiety, and then constantly assess for threats to life throughout management process. So rarely removal of an impaled object may be necessary, but if the object directly interferes with airway control and the patient is deteriorating, and then the object interferes with chest compression, we've already mentioned these, or the patient is impaled on an immovable object. So, establish contact with med control and just ask for some guidance about that. Now, avulsions, we mentioned that right at the beginning about avulsions and how that can become very distracting. So avulsions, that occurs when a flap of skin is partially or completely torn loose. Now, the amount of bleeding, that's going to be dependent upon the depth of the injury. And so the amount of bleeding is dependent on the location. And then the principal danger is loss of blood supply to that avulsed skin flap. So if the wound's contaminated, provide some irrigation with normal saline, sterile water, gently fold and align the skin flap back as close to its normal position. Cover with a dry, sterile compression dressing, and then don't remove the skin flap. So regardless of the size, never remove that skin flap. Ice packs on the surrounding area may decrease the pain and the swelling. Also can increase the length of time the underlying tissue remains viable. Now, if the patient is unstable, do not delay transport. Now, an amputation. So, amputation, an avulsion involving the complete or partial loss of a body part. So, with these, hemorrhage can be a real problem. They can be severe and life-threatening. So, if you think about it, obviously fractures can also be present. And then in a partial amputation, soft tissues remain attached. So those within these amputations, wound edges are usually going to be jagged with these. So be aware of sharp bone protrusions during wound care. If a body part is completely amputated, try to preserve it in an optimal condition for just the best chances, the maximal chances of reimplantation once the patient has been stabilized. So rinse off any debris using cool normal saline or some sterile water. Wrap it loosely in a saline moistened sterile gauze. Seal it in a bag, place it in a plastic bag. Place it in a cool container. Do not allow it to freeze. That's going to be really important. Never warm it, never place it in water, never place it directly on ice, and never use dry ice to cool it either. So transport the patient and the body part as soon as possible. So if that amputated part is a limb or part of one, you want to make sure you notify the ED staff of the type of amputation, and then obviously your estimated arrival time. And then bite wounds. So most people bitten by animals do not report it, but such bites can be serious. So cats and dogs' mouths are contaminated with virulent bacteria. Cat bites can pass along a gram-negative bacteria that can cause epiglottitis, endocarditis, brain abscesses. So all such bites should be considered contaminated and possibly infected. And then dog bites, may cause mangled and complex wounds needing surgical repair as well. Human bites, if you've been on the ambulance or any type of 911, you know that these can kind of occur at times. They usually occur on the hand. Human bites contain a wide variety of those same pathogen, not same, but some virulent pathogens. So any human bite that penetrates the skin should be considered a serious injury. So for an animal bite, place a dry, sterile dressing and transport promptly. Now, if there's gross contamination, irrigation with sterile water before placing a dressing should be considered. And then splint an arm or leg if it's injured. And then determine and document, so when the bite occurred, the type of animal, and then maybe note if the wound is a human bite and what led to the biting incident. So rabies, it's a major concern with dog bites. So it's an acute fatal viral infection of the central nervous system. It's pretty rare today. Once signs appear in a human, it's almost always fatal. So of particular concern are stray dogs and other wild mammals. The virus is in the saliva of an infected animal and is spread by bites or licking on an open wound. So infection can be prevented by a series of vaccine injections initiated soon after the bite. But a human bite, first thing we need to make sure we do, control all bleeding, obviously, apply dry sterile dressing, immobilize that area with splints or bandages, and then get headed out, provide transport. So most jurisdictions require that all animal bites be reported to the authorities, such as like an emergency department physician. Human bites are a form of battery, so they may require authority notification. And then pre-hospital care workers should know the local reporting requirements. Now, high pressure injection injuries. So what we're talking about occurs when a foreign material is forcefully injected into soft tissue. So these are often from a tool or a machine failure in which highly compressed air or liquid is suddenly released. So those injury results from injected material under great pressure entering the body. They can cause some acute and chronic inflammation. There's damage from the direct insult, chemical inflammation, ischemia from compressed blood vessels, and then obviously a secondary infection. So kind of some assessment and management. We're still talking about high pressure injection injuries. So primary survey, obviously address life threats, determine severity. So question a patient about the nature of the injury, so the type of equipment and the pressure used, the type of fluid in the event that was an issue. Inspect that injury for the extent of visibly damaged tissue. The greatest amount of injury is often under the visible tissue, and then palpate the area for signs of edema. Sub-Q emphysema may be present, so check for crepitus at the injury site. The treatment's pretty limited, gently irrigate the wound with some saline, dress and bandage, manage pain. Now, face and neck, so this may involve the airway or the large blood vessels. So airway compromise can arise from some substantial bleeding, like we mentioned before, disruption of soft tissue as well. Now, suction and patient positioning may be necessary for airway patency. So often injuries to the jugular or carotid vessels can result in exsanguination. So everything on the inside kind of coming out on the outside. And of course, psychological impact of facial damage can be a thing too, as we mentioned. Now we're continuing on. We're going to talk about facial and neck injuries. So they involve or can involve the airway or large blood vessels. So we mentioned the airway compromise can arise from substantial bleeding or just that disruption of those soft tissues. So just as before, suctioning and appropriate positioning may be necessary. Open injuries to the jugular or carotid can lead to exsanguination. So, that severe blood loss can be a big thing. So that guy, it says he's part of a gang initiation process. I don't know what that young man went through, but that's something they said. So assessment of airway patency. When we're talking about facial and neck injuries, we want to make sure that we're assessing that patency, the protection mechanisms, oxygen flow is necessary. May require use of an advanced airway, so maybe an ET tube, maybe a King airway, whatever it is that we're able to do with these type of injuries. You may end up having to go even further, so you might have to do a crike or something. So a surgical airway may be indicated on one of these patients. Now, if that bleeding is life-threatening, then we switch to that, remember that XABCDE. So manage the significant bleeding by applying bulky dressings and direct pressure. Open wounds on the neck need occlusive dressings to prevent the air emboli, and then just realign that avulsed skin along the face or neck to the original position if possible. And then of course, if the bleeding doesn't stop within the neck, that's where we'll put a tourniquet on. No, I'm just kidding. I was just seeing if you guys are listening, if I'd already put you to sleep maybe. So thoracic injuries may have some underlying chest trauma. So, there's 4 steps to this assessment. We're talking about nothing new: inspection, palpation, auscultation, and then percussion. So make sure you examine that entire chest for a visible injury. Listen to breath sounds in at least 2 sites on each side of the chest. Palpate the entire chest wall. So sub-Q emphysema is indicative of tracheobronchial tree disruption, because we're talking about thoracic injuries. And then open wounds require occlusive dressings to prevent or stop progression of pneumothorax. Abdominal injuries, so obviously inspect the abdomen and palpate the area. Here we're talking about obviously just minor abrasions all the way up to evisceration. So basically, kind of how I said exsanguination was the inside on the out, that's kind of what we're talking about. So some of the abdominal contents are now kind of peeking out, or maybe they're all the way out. So, as that diaphragm travels downward during inspiration, the relative size of the thoracic and abdominal cavities change. That increases the risk of drawing air into that pleural space if an open wound is present. That's going to cause some problems. So these soft tissue injuries in the abdominal area, not general primary concern. So focus on the injury to underlying organs and blood vessels, could quickly lead to serious complications. And then we talk a little bit more about abdominal trauma in another chapter. However, even if we do have an eviscerated organ, remember, ABCs are still going to take over. Precedents are going to be our priority, not necessarily that. And then myositis, so the inflammation of the muscle. It can be caused by injury, infection, overuse of a muscle. So some of the things that we want to look for: signs of infection, muscle weakness, fatigue on exertion, and then that treatment just based on the patient presentation. Because we're talking about infections now. Gangrene, so that's just some dead tissue, like what you see there. So causes injury, infection, long-term tobacco use. I assume it's because of some peripheral, basically resistance, just poor peripheral circulation. It's an anaerobic toxin producing bacterium that leads to development of gangrene. So that causes just that production of just this foul-smelling gas. If you've not smelt it, be glad. And if you have, then you know what I'm talking about. So wet gangrene, that causes sepsis. Those people can die within hours. Dry gangrene can take months to develop. A lot of times with this, that's caused by diseases such as diabetes or peripheral vascular disease. Burns, frostbite, wounds can also cause it. So these are things to really pay attention to, especially for people that are long-term. That's how you see in diabetics and other people that end up start losing things as the disease process kind of escalates. So suspect gangrene if they have a chronic risk factor such as diabetes, numbness, coolness, or swelling of an extremity, discoloration of the limb to black, blue, or even red, which is a late sign. And then if it's untreated, that skin will become necrotic, and infection can lead to sepsis. And then tetanus, caused by infection from an anaerobic bacterium. That causes the body to produce a potent toxin, which results in painful muscle contractions, strong enough to fracture some bones. So this is pretty rare because of the vaccine availability. Part of regular childhood immunizations in the United States. So a booster is needed every 10 years. Inoculation is usually given to patients with injuries who have not been vaccinated in the last 5. So ask the injured patient when they last received a tetanus booster. That may or may not be something that you put into your patient assessment, but they'll want to know in the ER, and whether you give it to them or the patient, either way. Assessment and management. So that muscle stiffness may be noticed first in the jaw, so kind of a locked jaw, and the neck, with the progression down the remainder of the body. So obviously with this, early recognition is going to be essential. Now, necrotizing fasciitis. So that fasciitis is just that inflammation of the fascia. So necrotizing fasciitis involves tissue death from bacterial infection. That's caused by more than one infecting organism, most commonly group A strep. So recognition by EMS personnel is difficult but critical. So early intervention is crucial. Look for insect bites, puncture wounds, skin may be reddened and warm. There's additional symptoms as well, so fever, night sweats, chills, vomiting, diarrhea, all of those things. Make sure you got standard precautions on these. And then if that's something that someone has, antibiotic therapy and then some surgical debridement, they may be some of the things that are needed. That's what's available. Not sure how to pronounce that, so I'm not going to. But the most common infection of the hand in the United States, so a bacterial infection that's located near the nail plate. If it's not recognized and treated, it can spread through the hand and into the circulatory and lymphatic system. Now that's going to cause a small pustule or redness with or without pus, and there may be an abscess at the site. So they're going to be probably getting some antibiotics as well as potentially lancing those abscesses. There's so many words I'm unfamiliar with. So flexor tenosynovitis is caused by an infection, though, that's usually the result of penetrating trauma. So that involves the sheath of the tendons that flex the fingers. So if they have the inability to extend the involved finger, pain and swelling along with the path of the tendon, and then it occurs chronically in patients with a history of rheumatoid arthritis. Then it can present looking like some swelling and redness and then just some limited mobility in that hand. This seems to be everyone's favorite. This has gone pretty fast. I'm talking fast and we're just not going deep in things. So there we are at the end. You're welcome, and we'll see you next time.